My podcasts are a good antidote for insomnia. So, okay. Thanks, Eric. The easiest place to find my educational stuff, it's paramedictutor.wordpress.com. It's pretty. So I'll introduce myself. I'm Rob Theriault, and I'm from Ontario. That's usually how I tell people how to pronounce my name, Rob Theriault from Ontario. And I've been in EMS for 26 years. Started in Toronto, moved to British Columbia, worked there in Whistler and North Vancouver. I'm still not sure why I left Whistler. And then I took a job in Toronto with the air ambulance and worked on a helicopter for 10 years and trained as a critical care flight paramedic. And then I took a full-time educator position and continued part-time on ground ambulances, an advanced care paramedic. And currently I'm teaching at Georgian College in Barrie, which is an hour north of Toronto on Kempenfelt Bay, teaching the primary and advanced care paramedic programs there. And working part-time as an ACP on weekends and full-time in the summer in Halton region, which is Oakville, Burlington, just west of Toronto, that area there. So glad to be here. And I'm going to do a little presentation on syncope. And one of the reasons I like syncope is because I think a lot of people perceive it as this benign event. And in most cases, syncope, as you know, is a benign event. You know, people just simply faint. But I'd like to talk about the ones that are a little more insidious and have the potential to be life-threatening. So we'll talk a little bit about some of the pathophysiology. Now, how many of you are practicing paramedics? RNs? Educators? RNs and paramedics? No? Okay, good. No educators in this room? Okay. Okay. Let's go through some definitions and a couple of things. So, syncope, you're all familiar with syncope. It's an abrupt loss of consciousness, which is transient and self-limiting. And people land on the ground, and blood flow is restored to their brain, and they recover spontaneously, and people recover quickly. So it's a loss of consciousness. It's very brief, very transient. And it excludes things like seizures, coma, shock, and other forms of altered level of consciousness. Let me just get through here. And in terms of patho, so it's a global hypoperfusion of the brain. So there's interruption of blood flow to the brain for whatever reason. What's the most common form of syncope? Yeah, orthostatic. Some used to call it vasovagal. Now they call it neurogenic syncope. I'm not sure why the term vasovagal went out of vogue, but we all still use it. So, yeah, so we have the sudden vasodilation effect, blood pools in our periphery, and we lose consciousness. And usually that happens, you know, when people are standing and not moving a lot. And what's the trick for staying conscious and not fainting when you're standing for long periods of time on a hot day? Anyone know? Don't lock your knees. What do the British soldiers do? Those guys with the big tall hats and what's that? Curl your toes. Yeah, curl your toes. Contract your leg muscles. Pretend like you're squeezing a peanut between your butt cheeks. Something like that. Usually works. I don't think the audio recorded that. Could you just say that again? I'm kidding. So blood is the brain is a pretty interesting organ. It weighs about 2% of our total body mass and requires about 25% of the body's energy. So it needs blood flow. It needs constant supply of glucose. There are only 3 organs in the body that need a constant supply of glucose that don't have glycogen stores. Anyone know which organs those are? The brain, the eyes, and the other organ only men have, the gonads. Interestingly enough, why that is, I don't know. But anyway, so the brain needs blood flow, constant blood supply of glucose, and it doesn't have the ability to store energy. And so if blood flow to the brain is interrupted for as little as 3 to 5 seconds, then we have a loss of consciousness or a syncopal episode. And by the way, if you are taking notes, I am going to send the slides to Eric, and he's going to post them, I think, so people can make attachments. I actually made a copy, but apparently the only photocopier the hotel has is one that will only copy one page at a time. You have to put it underneath the cover. Anyway, so yeah, so in terms of patho, so our cerebral perfusion is maintained at a fairly constant state, despite various fluctuations in blood pressure and heart rate and so on and so forth, and that's through a whole complex series of negative feedback mechanisms and negative feedback systems. And so it requires a pretty steady cardiac output, systemic vascular resistance, arterial pressure, normal volume status, cerebral vascular resistance, so intracranial pressure, and this complex thing called autoregulation. And as you know, when we go into cardiac arrest, we lose autoregulation. It takes some time to restore that post arrest, but that's another topic. And requires metabolic regulation of things like glucose, oxygen, CO2, CO, maintenance of thyroid hormones, those kinds of things. So we're going to look at some of the pathophysiologies that affect these different systems. And so any defect in one of these systems can result in syncope. And the differential diagnosis, this is probably the most important thing that I try to convey to my students when we talk about syncope or any medical or traumatic condition, is that we have to be really careful not to look at a collection of signs and symptoms and just make a leap to, okay, this is the cause. We have to think in terms of lists and do some critical thinking to get to that level. So one of the things I try to really emphasize with my own students is to come up with a differential diagnosis. And I just put this long list in here, not for the purpose of having you read it or remember it or write it down, but just to make a bit of an impression that the differential diagnosis for syncope is pretty big. We have, did any of you attend my morning session? I talked about, okay, do you remember I talked about respiratory alkalosis, people hyperventilate? Well, there's a cause of syncope, right? People blow off too much CO2, they get cerebral vasoconstriction, hemoglobin becomes a strong magnet that holds onto oxygen, doesn't release the tissue. They lose consciousness. They suddenly, the metabolism sort of settles, blood flows back to the brain, they wake up, and everything seems fine again. And a whole bunch of other things. But the causes of syncope that you and I, as first-line providers, should be most concerned, I think, are some of the cardiac ones and some of the subtle ones. And it's as you know, it's really a lot of detective work to go on scene and try to distinguish between the benign syncope and the potentially life-threatening syncope. And a lot of that really comes from the history of presenting illness and the history of presenting illness in particular, and some of the clues in there when we get some interesting answers to the questions that we ask, and some of the family historical information, some of the risk factors that those patients might have. So I've created this red flag list, and I'd really hoped would be able to copy that sheet, but wasn't able to do that. And these are sort of the red flag things that should alert you to the possibility that this might be more than just a vasovagal episode. Syncope is not unheard of, but is unusual in the pediatric population. In terms of risk factors concerning age groups, there are three sort of distinct risk stratifications with ages. One is anyone over the age of 45, then anyone over the age of 65, and then anyone over the age of 80. So increasing levels of risk, obviously, for syncope that resulted from a serious cardiac event. So anyone over the age of 65, pediatric. Pretty rare in infants, and most common we see syncope in young adults. One of the other red flag risk factors would be, or what history presenting illness would be, syncope that happens as a result of exertion. So exertion preceding the event, anyone who is dyspneic preceding the event, any history of pain or palpitations pre-syncope. This is the one I like. People who faint from a sitting position or from a lying down position. This is something I found paramedics where I work don't often think about. Most of the syncopes we see are they're standing, and generally when I ask a crowd of students who they think is at greater risk or who is more of a concern for you, the one who faints from a standing position or the one who faints from a sitting position, most people answer standing, because when they're standing, we worry about trauma, right? But from a a cause standpoint, from an etiological standpoint, the more concerning syncopes are the ones who faint from a sitting position or from a lying position. Because if they're fainting from sitting position, you start to wonder, is this vasovagal, or is it more likely a cardiac event, an arrhythmia, something of that nature? So sitting, semi-recumbent, lying down, any history of cardiovascular disease and syncope, any unexplained sudden cardiac death in the family. Now, this is a tricky one to ask, right? You know, do you have any past family history? Are you taking any medication? Anyone die in your family suddenly by some unexplained means? That is to say, you know, no one's under investigation, you know, being questioned by police at the moment. So I'm not quite sure how to phrase that question to people, you know. So, any people die in your family early in life? But you've got to put that question to them. Any history of recurring episodes of syncope, any prolonged loss of consciousness with syncope, and then we don't really think so much of syncope. We think of, you know, other causes of loss of consciousness, medications that affect cardiac conduction, and abnormal ECGs. And I'll talk about some of those abnormal ECGs that we'll look at. So I've got some cases, and when I thought about this, I probably could have put together 20, 30 cases, but I narrowed it down to 7. You know, when you're invited to speak at a conference, you really have to force yourself to whittle down your slides, and I always start with about 50 and whittle it down to about 20 or 25. And so I've come up with 7 cases, and some of these are patients I've had. Some of them are patients that either my graduates have had or I used to work as a program manager with a base hospital, and some of my medics have had. So here's the first case. So this is a 47-year-old previously healthy male, had a near syncopal episode, and the story was he was at Mass. It was the end of Mass. He was standing, and he just kind of got woozy and went down on the bench and laid down on the bench, and everyone, whoa! And so it's unclear whether he actually lost consciousness. It sounds like he didn't actually lose consciousness. So he had what I would describe as a near syncopal event, and a couple of paramedics who worked under a base hospital responded to this call. And so they took a history, and this guy, at this point, he was sitting out at the steps in the front of the church, and most of the congregation had left. And when the paramedics arrived, he said, "Hi guys, you know, I'm fine. I'm good. You know, thanks for coming. You guys are great. Is there a form I can sign or something? Just thank you a lot." And they said, "Well, why don't you let us take a history, you know, get the story first, and we'll do a couple of tests and just make sure you're okay." And I think they were thinking, well, they told me they were thinking that they might not need to carry this guy. So, you know, they got the story, and they asked the usual questions. Did you have something to eat today? Have you been unwell at all recently? Any medical history, meds, allergies? It's negative for all that stuff. Although he did say he had 2 similar episodes within the last 6 months. But again, they were just kind of not full losses of consciousness, just kind of near syncope. And so they did the usual things, and they checked his blood sugar, which, you know, we do as a routine on all patients with an altered level of consciousness or who have a syncopal episode. There was no significant history for cardiac disease, no history of sudden deaths in the family. And then so then we start to look for some of the other red flags. So here's his ECG initially. Does anything look out of whack with that ECG? Not really. It's just a sign. It's always bad when you put up an ECG and you ask that question. Does anything look wrong? Because everyone's looking, what's wrong with it? I don't see anything wrong with it. Rob's trying to trick me. Yeah, it's a pretty normal cardiogram, right? It's heart rate's 300, 150, 175. There's P waves, there's QRSs. Nothing looks out of whack. Nothing looks abnormal. So he was previously healthy. So while they were assessing him, sitting on the stairs, interesting thing. So he's sitting there, and they're talking to him. They've got him hooked up to the monitor, and he does this. And one of the medics grabbed him by the shoulder and said, "Sir, sir, sir." So he went into this kind of catatonic state. Now, be honest, what would you think if you saw a guy who just kind of phased out, just suddenly deer in the headlights, not responding to you? Yeah, I would think like a seizure, right? Like a seizure. I would be thinking the same thing, and that's exactly what they thought. But so they were thinking that too, but one of them was looking at the monitor and ran a strip simultaneously, and this is what they found. So here's his ECG before he went catatonic, and then you can see here it's starting to slow down a little bit. he's starting to bratty out here, still bratting out, and here he went flatline, and was flatline all along here, and then over here he had a spontaneous beat again. So what's the term for that when you're in a sinus rhythm and you go flatline for a little while? No, that's something else. That's sinus arrest. It's a sinus arrest. Yeah, ventricular standstill is where you see like an asystole, but with P waves. So not too dissimilar. So anyone know what is the most common cause of I almost gave you. Yeah, thank you. The sinus arrest. Yes, it's sick sinus syndrome. Exactly. So I'm not sure that that's what he had. And what's the treatment for this guy? Pacemaker, right. So he needed a pacemaker. So this is when he phased out. He went catatonic. Now, you know, it struck me when they did this call. This was, when was this? This was 2000 or so. You know, it had only been about 3 years since primary care paramedics were being taught ECG interpretation beyond the shockable rhythms and the arrest rhythms. So they were pretty savvy to monitor his heart rhythm and run a strip at the time when this guy went catatonic. I thought that was quite clever. So that was his issue. And the interesting part was, yeah. Sure. Let me just finish off what happened with this guy. So I'll just finish the last little bit. So the interesting part was he goes catatonic, right? He's like this. Thanks a lot, you guys. You guys are great. You guys do a great job. Where can I sign? You know, I feel good. I'm good. You know, I don't want to. You know, you guys are busy. I don't need an ambulance, really. That was kind of how he ended things. But they transported them, of course. Yeah. So, yeah. Sure. Story.
We got called quick for a fall. She had a broken, and when we took her pulse, we noticed it was in the 30s.
Yeah.
So we put her on the monitor. By that time, she was back like in the 80s or whatever. And I just said, you know, like, have you fallen before? She said, yeah, as a matter of fact, she said like twice now in the last like month or two.
Yeah.
And I've gone to Victoria, and her started comment on how slow I felt. And did they do anything? She said no. So in the truck, put her on the monitor, and she had probably 2 or 3 episodes of sinus arrest that lasted about 10, 15 seconds at the most or whatever. So we made sure to tell Emerge, doc. And they got a 12-lead done on her pretty quickly. And literally while she was having a 12-lead, she had a 1-minute episode. They were about to start.
Compressions, wow.
And within half an hour, she was in the cath lab to get a
Yeah. Yeah, interesting. And sometimes you get people with intermittent secondary AV block type 2 that have syncopal episodes, or just near syncopal episodes. They faint, and of course, at that age, you know, they break things. So yeah, not good. So case 2. This is a 68-year-old male. This wasn't one of my calls. One of the medics where I worked. So 68-year-old male collapsed in the bathroom while shaving. History of TIA 7 months ago. Capillary blood glucose was normal, and ECG is on the next page. Now, do you see any red flags in that list there? Yeah, TIA and the one other thing there. Yeah, I mean, that's not old at all, but he is over 65, and, you know, the risks start at 45, and I guess then they escalate to 65. I don't know, where do they get these numbers? I don't think they pick them arbitrarily. I think there's a reason, but it just seems odd, you know. It's probably 64.3, but they just rounded up to retirement age, and I swear to God, I will never retire. Every time I go to a cardiac arrest, well, I shouldn't say every time, but I go to so many cardiac arrest people who've retired within the last 6 months, or they're having the big MI. It's very stressful to retire. Yes, he was. He was standing shaving. And here's his cardiogram. Anything unusual? I'll just tell you no, not really. Nothing out of the ordinary. Another trick ECG. Damn that Rob Theriault. Why does he do this to us? Don't you? I don't really like that teaching strategy, but there's nothing abnormal about this cardiogram. Nothing to write home about. So what do you think happened here? Anyone know?
Did he just come out
Nope. He did. Do you know how? Yeah, the shaving. Yeah, this is called carotid sinus syncope. So some people who have a buildup of atherosclerosis in their carotid arteries, just by either turning their neck, stretching their neck, and shaving, and applying a little bit of pressure on the carotid body, or or wearing a tight necktie. You know, you get the old guy in the church who's got the necktie on a little too tight, and has a syncopal episode. So that's all that happened. He just stroked his carotid body, and the baroreceptor said, "Oh my God, there's a sudden increase in pressure." You know, vasomotor center said, "Shut down the system, abort." No, he just had a syncopal episode. That's all he had. So it was just a vasovagal episode because he put a little bit of pressure on the carotid body, and that's what happens when you get a atherosclerotic buildup on the carotid artery. So stretching the neck, shaving the neck, turning the head, tie too tight. So here's case 3. So this is a 24-year-old previously healthy female. She's at the gym. She collapsed suddenly in the change room, and this was actually before she had her workout. So this was from a standing position, and that's always a concern about trauma, of course, so we do a trauma assessment. And she did have a history of a sudden death in the family. Her dad died when he was 36. It was an unexplained death, and no one in the family was under investigation for murder or anything like that. Not that kind of an unexplained death. Her capillary blood glucose was normal. Do you guys use that short form, CBG, or do you use BGL, blood glucose level, or what do you use? CBG? What's that? BS? BS. I only recently started using CBG because the hospitals where I work use CBG, and the first time I saw that, I said, "What's CBG? I know what ABG is, and I know what CBC is, but what the hell's CBG?" That's right, CBG. It's the Canadian Broadcasting Group. It's the pirate version. Her PR, well, that's a good question. What is her PR? I actually don't know. I actually didn't measure her PR interval. Well, there might be. So it goes from here to here. So that's looks like 1, 2, and 3. That's 5. It's just kind of on the border, right? So it's about 0.20. But what are the red flags in here for her? So age is fine. It's not exertional, but the father died. Well, no, actually, that's not. Interestingly enough, there is no difference in terms of risk of syncope between ethnic groups and between the sexes. So men and women. Oh, okay. Yeah, okay. Anything in that ECG jump out at you, though? No? Okay. Good eye. The amplitude is a little low, so we'll do a 12-lead ECG to see what's going on. But the QT, yeah, the QT is long. How do you measure QT intervals? Nobody. Yeah, most people don't. I teach people to do that because people with prolonged QT are predisposed to this rhythm. Does anyone know what this is? Recognize this? Yeah. That's torsade de pointe. It looks like ventricular fibrillation. The cardiac monitor analyzes it and interprets it as a shockable rhythm. It will shock it, but it's a torsade de pointe. It's a polymorphic ventricular tachycardia. But it looks like just VF, like VF. And people who have long QT syndrome are at risk of torsade de pointe. So they're at risk of sudden death. The interesting thing about torsade de pointe, it's kind of like sinus arrest, where your heart stops beating and you have this period of asystole, and then your SA node spontaneously kicks in, or some ectopic beat spontaneously kicks in. I find that fascinating because it's like a little brief episode of death. Torsade is kind of like that too. It's this shockable rhythm that starts and ends abruptly. So they may have a syncopal episode, and then boom, they're back into a sinus rhythm. So that's what happened to this. One of the girls who worked for in the service where I worked at the base hospital, she was transporting this patient who had the syncopal episode. No one really thought a whole lot of it. The girl had something to eat. She was fine. Everything else was good. And then the back of the ambulance, her eyes rolled to the back of her head. She had a very brief hypoxic seizure. And the medic reached for the defib pads, got the defib pads slapped on very fast. And as soon as she got the defib pads turned on and defib pads applied, and before she could hit analyze, the patient converted into a spontaneous rhythm again, and kind of woke up a little bit and wondered where she was and felt quite dizzy. So she ran the ECG while she was getting the pads, and this girl converted back into a sinus rhythm. So, sorry, I thought I had the 12 lead here, but I don't. So the issue here is that she has a prolonged QT, and it's a little difficult to appreciate from this slide. Hang on a second here. But so QT is from the onset of the QRS, sorry my line's not very straight, to the end of the T wave. Let me just erase those and do this properly. So the onset of the QRS to the end of the T wave. And the distance between the Q wave and the T wave should be equal to half of the R to R interval. The half of the R to R interval is about here. So her QT is greater than half of the R to R interval. And that's a quick way to eyeball it. A medic once showed me that you take an ECG strip, and you know how you can fold an ECG strip over itself and line up the QRSs to see if it's a regular rhythm? We can do the same thing with QT if you're really good. You fold it so that two adjacent R waves are on top of one another, and you make a crease. And then when you open up the crease, if the T wave is past the crease, you've got prolonged QT. And if it ends before the crease, then you don't have prolonged QT. Little tricks you learn in the field. So slowly, yeah. So there are a whole bunch of different causes of prolonged QT. In some cases, it's congenital; they're born with it. Do you know what other defect is commonly associated with prolonged QT syndrome? A birth defect, something to do with one of their senses. They're missing one of their senses. Their hearing. People born deaf. Very common to have prolonged QT syndrome. People are born deaf. So she's definitely a red flag for the reason that there was a sudden death in the family. And this is a question. Do you guys ask that question? I never used to ask that question. It's just not one of those things you think of. Anyone die suddenly in your family? What's that? Any stress in your life? Yeah, that's probably a good way to put it. Maybe then that other information comes out, right? And you can lead to that. So prolonged QT. So I highly recommend looking at the QT intervals as a routine whenever you're looking at ECGs and interpreting ECGs. Now, when you do a 12 lead, you can look at the QTC interval, which is, they call that the corrected QT interval. And what that means essentially is that unlike the PR interval and the QRS duration, the QT interval changes with heart rate. It gets a little longer with slow heart rates, gets a little shorter with fast heart rates. And so they call that a corrected QTC. And or corrected QT. And on the 12 lead, it's very accurate. And does anyone know what a prolonged QT is on a 12 lead when you see those numbers? Anything greater than 44 milliseconds. Anything greater than 44 milliseconds. And actually, it's a criteria for selecting or preventing people from going into the Olympics. They look at their QT interval, and if they're, I think, in excess of 44 for men and 46 for women, they're excluded from the Olympic competition. Yeah. There are. I'm just trying to think now which ones do that. But there are a number of drugs that prolong QT. I remember the one that, what was that one? Let me think about it while we go through the next cases. So, let's see here. What time is it? 5 after 4. Did we start at 3:30? So we're going to 4:30. Okay, I was nervous there. I thought I was way over my time here. Had a mini panic there. There we go. Okay. All right. So she had a bout of torsade de pointe. Interesting. And the remarkable thing for you and I as frontline providers is if we're going to catch the cause of their syncopal episode, it's most likely to happen with us as opposed to later on in the hospital, because those things like sinus arrest and torsade de pointe just seem to be elusive. And so many people present to the emergency department with vague signs and symptoms, and they get referred to cardiology for a Holter, right? And then they get a Holter done, and sometimes that'll catch it within 48 hours or 72 hours, but not always. I used to work as a cardiotech at the New Westminster Hospital in British Columbia as a cardiotech, and used to do Holter scanning on night shifts, which was, let me tell you, that's a lot of fun. looking at ECG complexes on a computer screen in the middle of the night. So sometimes you would catch those things. It was interesting. So case 4. This is a call. Well, it wasn't a call I did actually, but George Bush Sr., former U.S. president, the one who was more fondly thought of than the subsequent George Bush, was at this state dinner in Japan, and he collapsed. And so I read about it with some interest because my partner and I were assigned to look after George Bush Sr. When he came to the All-Star game in Toronto. So I was under surveillance by the RCMP. I thought because they were worried I was a terrorist, but as it turns out, they just wanted to make sure no one got to me. So there was this very conspicuous guy parked in an unmarked car outside my apartment building for 2 weeks straight, leading up to this event. But anyway, so it was a great experience, and I was interested to know a little bit about President Bush's health because I'd never been assigned to a president before, and it was pretty exciting, and I wanted to make sure I didn't screw up. And so he had this collapse at a state dinner that was first reported as the flu, and later described in the news as a thyroid condition that led to a sudden irregular heartbeat. So what are the red flags here? One of them I forgot to jot down, but age, yeah. So so it's age. I can't write with this thing. And he was sitting. That's a red flag. And anything else? Yeah, sudden onset, but all syncope has sudden onset, right? What's the other one, though, here? Oh, you mean this? Yeah, sudden, yes, for sure. Yeah, sorry. Yeah, okay, gotcha. We're on the same page now. It takes me a while, but eventually I get there. And the other one, of course, is this thyroid condition, right? So anyone know what this might be? What he might have had? Yeah, he had a hyperthyroidism. Good. Yeah, what do we see most commonly? Hypothyroidism, right? He had hyperthyroidism, and they're predisposed to what? He was hyper. Yeah, hyperthyroidism. And anyone know what type of dysrhythmia he might be prone to that would cause him to lose consciousness briefly? AFib, yeah, paroxysmal bouts of atrial fibrillation, exactly. Paroxysmal atrial fibrillation. So it was kind of cool because so we got into our Bell 212 helicopter and we flew out to Air Force One to meet the president and Brian Mulroney, who was then the Prime Minister of Canada. And we didn't actually, not to meet them, we just landed and the airplane was far away and we saw them as little dots in the distance. So I don't want to embellish too much. And we flew to the Sky Dome. It's called the Sky Dome then. Now it's called the Rogers Center. And we landed by the CN Tower, and we went in. We were in a little booth, private booth, next to the booth where George Bush and Brian Mulroney were. And the interesting part was at the start of my shift, we were using the LifePak 5s back then, these anti-cardiac monitors. Has anyone ever used the LifePak 5s? Anyone been around long enough? Really? Yeah, LifePak 5, okay. Yeah, anyway, old machine. And it was a great machine. The way to tell if the battery was getting low is you'd run the ECG strip, and it would make the sound, ee, and if the battery was getting low, it would go, ee. That's how we knew to switch out the batteries back then. Very technical, exactly. It's very technical. Not the ones we had, but yeah, the ones that came later with the Analyze automated. So anyway, we had 2 defibrillators left, and they were both broken. And so I went to my manager and I said, George Bush is coming, and we don't have a defibrillator. And he said, Rob, nothing's going to happen. Don't worry about it. Come on. And I'm a Murphy's Law kind of guy, and is the President of the United States, and I don't want to be the guy on Oprah who has to explain that my defibrillator didn't work, No, or in a court of law. Rob Theriault, I understand you're a pretty good paramedic. How is it that you missed this important equipment check in your daily routine? Well, Oprah. It wasn't me. So anyway, I finally convinced my boss, and we contacted another service, and they sent an ambulance, lights and sirens with a defibrillator for us. But of course, we didn't need it, so all was good. But that was his issue. He had paroxysmal bouts of atrial fib. The cool thing was we got into the helicopter with me, my partner, a sniper, which made me nervous because I wasn't anticipating that a sniper would come along with us, and a colonel who was his physician. And so the physician said to me, do you want a debriefing about the president? And I said, sure. I understand, though, that he has hyperthyroidism with paroxysmal bouts of atrial fibrillation. I was just kind of saying it tongue-in-cheek, right, just to see, if I get a rise out of it. And he looked at me like, how do you know that? Well, yes, I'm a member of CSIS also. So I said, well, I read it in the Toronto Star, kind of. So case 4. Let me move along here. So, oops, what's happening? I'm going backwards instead of forwards. Okay. Oh, this was his... This is what his ECG might have looked like. That wasn't his ECG, obviously. I could actually see him pretty closely. Like if he had made eye contact with me, we both would have smiled and acknowledged each other's presence. But I couldn't get close enough to do a cardiogram on him. But anyway, this is what it looked like. Now the interesting thing about rapid AFib is it looks like SVT, right? Does anyone know a good little pre-hospital trick for distinguishing rapid AFib from SVT? It's much easier than you think. Way easier than you can possibly imagine. No, all I do is turn the volume up. You can always tell by the sound, right? Because if you look at it, you have to map it out. You get a piece of paper, you line it up, you do all that stuff. But if you turn the sound, you'll always hear beep 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 beep. You can tell from the sound, right? That's how I know. That's how you tell whether or not to give adenosine or something else, right? So case 5. So, what's that? Is that how you defend it too on Oprah? Exactly, on Oprah. That's exactly, well, Oprah, this is how we do things outside the hospital. It's all about rhythm. So this was a 34-year-old, previously healthy male who had syncope during sex. Now, I've known people who've said, their orgasm was so intense they thought they were going to pass out. But so this guy actually did. And he had one previous episode 3 years ago, quote-unquote, from the flu. His father died suddenly at age 58, which is not unusual. My dad died at 58 from a heart attack, but he died at age 58. His blood sugar was normal. ECG is on the next page. Any red flags here? Yeah, exertion. Okay. We're assuming that was exertion. I mean, it's... Anyway, that's yeah. Anyway, let's not go there. Whoops, what's happening there? What else? Yeah, he's had it before. Yeah, dad died unexplained. 58 is young, but not extraordinarily unusual. Anything else there? What's that? Yeah, he's healthy. Shouldn't be having syncopal episodes, especially during sex, because presumably, yeah, we didn't actually even ask the guy if he was laying down. I didn't think to ask that question, but that was just kind of in the category of TMI. I know. I remember. Yeah. Anyway, that's another story. So this was his cardiogram. Actually, in fact, this is not really his cardiogram. The cardiogram I didn't get a scan of, unfortunately, but this is a facsimile of his cardiogram. So this cardiogram looks pretty much identical to what he had. So do you see anything unusual here? And I expect no one to actually recognize this, but if you do, I'll be quite impressed. Yeah, there is some unusual stuff happening here. There's pointed P waves, you said? P as in Paul? P waves? Are they peaked? I'm not sure if they are or not. The P waves, right? Which lead are you looking at? So did you say T or P? I have to ask again. P as in Paul. Okay. I don't see P waves, but He does have, here's a baseline, and there's a J point right here. So that's elevated above the baseline. It's a little unusual. And we've got sort of the same thing happening over here, and we've got a little bit happening there. Yeah, QRS is a little off, and he has kind of almost a right bundle branch block pattern in V1, right? But you notice the ST segment. It's not like a classic MI ST elevation. It's kind of a coved shape. It's kind of a rapidly descending ST segment. And this is the other thing we don't see. When you see ST elevation and you suspect MI, what's the other change you look for in the ECG that would increase the specificity of the 12 lead? Sorry? Right, reciprocal changes, yeah. So when you see ST segment elevation consistent with signs and symptoms consistent with cardiac ischemia, and then you see reciprocal changes, that's pretty strong evidence you're having an MI. But there's no reciprocal changes in this, and I don't expect many people to know what this is, because in fact it was only first described in the 1990s, and this is called Brugada Syndrome. Have you heard of this now? Brugada's? Okay. Don't feel bad. Like I said, it was only described in the 1990s, and it's a really interesting syndrome. It is purely an electrical phenomena. They call it a channelopathy. It has to do with an issue with fast sodium channels. And so they have an issue with their fast sodium channels, and they are at risk of sudden cardiac death. And there are, of course, if you've Googled sudden death, you'll see like prolonged QT syndrome support pages. There's a Brugada support page on the internet for people who just died suddenly, unexplained. This guy just fainted during sex. I can't think of any better symptom to experience to diagnose this with. And so there are three types of ECG changes in Brugada. This is the one that's diagnosis. This is type 1. And they have, so ST elevation V1 and V2, they have this pseudo right bundle branch block or IVCD, which is intraventricular conduction defect, which is just kind of broad term for we don't know what the is going on, but the QRS is a little bit wide. Cardiologists love to use sort of broad overviewing terms, like supraventricular is everything above the bifurcation of the bundle branches, that kind of thing. And so they have a history of syncope or near syncope, and that's kind of a red flag clue. And they account for about 5% of sudden cardiac deaths. Of all the cardiac deaths we see in the field, they account for about 5%. So chances are very good. If you've been in this career for 5 years or more, you've seen at least one Brugada. That's a really good question. I remember just reading that recently. I think I don't want to venture a guess, but I can Google it. It's more predominant in men than in women, but we'll Google it as soon as we're done here because I can't remember what the incidence is, but it's fairly high. It accounts for 5% of the sudden cardiac deaths we see. So, yeah. You might see this post-syncope, you might see this pre-syncope. So if this was a guy who was fortunate enough to have a 12-lead done pre-syncope, you might see something like this. So it's a STEMI mimicker, right? So we talk about STEMI mimickers like early repolarization and things like that. This would be a STEMI mimicker. It's so it's purely an electrical phenomena, and the treatment, they need an internal cardioverter defibrillator. That's really the only thing that will save these guys and will keep them alive. So case 6. Is a 19-year-old previously healthy firefighter student. This happened at the college where I teach. Every year we run this thing called, or the pre-service fire program runs this thing called the Camp Bucko Combat Challenge. And it's to raise money for Camp Bucko, which is a camp for kids with special needs or disabled kids. I can't remember exactly, but my paramedic students get involved and do assessments before these girls and guys go out and do this competition. It's a very intensely physical competition, part of which is dragging this heavy mannequin. And now actually our students, the pre-service fire students in our competition, don't have to wear the breathing apparatus when they do that, but they drag this thing. And so this guy collapsed during a competition involving dragging a heavy mannequin. He regained consciousness quickly, but he remained hypotensive for more than 60 minutes. Now, I don't want you to think that my students who were doing first aid held on to him for 60 minutes. They didn't. They called for an ambulance, but in hospital later, he was still hypotensive. So he had essentially decompensated. He had no past syncope, but he did have a previous history. When the nurses pried in the hospital tried to get a little more information, he did admit to having some chest discomfort a couple of times in the past. And that's what you'll see with this condition. His blood glucose was elevated. Is that normal during exercise? Yeah, it is. You get any trauma patient, any fight or flight response, any exercise, you release your glycogen stores, your blood sugar will be up. So it was elevated. ECG is the next page. And now this is not his actual ECG because we couldn't get that, but here's one that looks similar. So this would be really unusual for a 19-year-old. You expect to see this in maybe an 80-year-old. Someone talked about the voltage criteria earlier. Do you see any voltage criteria that really stands out? The amplitude, yeah. It's the height of the R waves and the depth of the S waves. And do you know what this is an indication of, usually, or suggestive of? It's ventricular hypertrophy. The greater the size of the muscle mass, the greater the electrical voltage. So when you've got S waves that are 30 millimeters deep or greater, or in V1, V2, or R waves in D5, V6 that are 30 millimeters or more higher, then you've got an ECG suggestive of left ventricular hypertrophy. Yeah. Any kind of exertional collapse, any kind of exertional syncope. Someone who collapses who literally has a syncopal episode from exertion should scare the bejeebers out of you. And he would have had left axis deviation, yeah, pretty significant left axis deviation. And so he had exertional syncope, and he was diagnosed later with hypertrophic obstructive cardiomyopathy. And so not only do they get an enlarged left ventricle, but part of the problem is that they get a very large intraventricular septum. And sometimes that interferes with blood outflow from the heart. And so with exertion, it interrupts blood flow. So they have interrupted perfusion of the brain, and they collapse suddenly. So cardiac output's reduced because they may have subaortic muscular obstruction, intermittent coronary artery compression, and or diastolic dysfunction. So poor ventricular filling, because they have this large, ineffective muscle mass. And oftentimes, cardiomyopathies are diagnosed in athletes who collapse exerting themselves. There was a hockey player a few years ago. I can't remember his name. I don't watch hockey because I grew up with three sisters, so watching hockey was against the law, just like. Yeah, okay. Yeah, I was just thinking of that guy who caused syncope from shaving his neck, and I was thinking of my sisters who and the whole hockey thing. One of the other things that my sisters forced me to do when I was growing up is the toilet seat always had to be down, right? So I just kind of gave up and just sat, right? And when I think about this guy who caused himself syncope when he was shaving, one of the other common causes of syncope with men, generally over the age of 40, is micturition syncope, right? As your vagus nerve innervates your genitourinary tract, typically when you get up in the middle of the night to pee, if you stand to pee, you lose consciousness, you hurt your head, all kinds of trauma problems with that. So I generally recommend that men re-potty train themselves when they hit about 40. Just sit. And if you're like me, you're smart, and you get the iPad to take with you. Lots and lots of time in the bathroom. There's always risk of. That's it. Yeah, that would be it. Unfortunately, yeah. Which is really unfortunate. Yeah, so case 7, last case. So this is a 12-year-old previously healthy male who had a syncopal episode during a visit to a college program. This was a kid who came to one of the sessions. We do these sessions for grade 7s and 8s at our college. We call it, I can't remember what we call it. We have so many events where the kids come. But anyway, I don't know what it is. I don't show gory pictures. I don't talk about anything awful, but I always get kids fainting in this group. And anyway, so this kid came, and he was a previously healthy male. and I actually got to speak to his parents a few weeks later, and they told me the whole story. So that's how I got this information. And I asked them, would you have any objection, or would your son have any objection if I shared this with my students and other people, just because of the story? So he had syncope from a standing position. His blood sugar was normal. ECG is on the next page. Not his ECG, but something similar. Any red flags here right off the bat? Yeah, he's a pediatric, right? So that's a little unusual. Good. Cardiogram. Anyone recognize this? Wolff-Parkinson-White. Yeah, delta waves. Yeah, these are delta waves. And you don't expect to see this in a healthy 12-year-old. So they have a short peer interval, and they have this delta wave. So they have this, where am I now? This R wave that slopes up like that, and a short peer interval. So you can see little tiny. Now, you would never know from looking at lead 2. So if all you did was lead 2, you just look at that and you go, yeah, big deal. Everything's fine there. But this is why, and this is not done routinely, anytime you have someone with syncope, they should get a 12-lead ECG. That should be routine. Blood glucose, 12-lead ECG. Because we're looking for things like ventricular hypertrophy, prolonged QT syndrome, evidence of fusion beats, which is what we're seeing here in this delta wave. And the fusion beat is essentially, when you look at the heart electrophysiologically, what's happening here. I'm really going to try to draw this. It's going to be difficult, but that's your conduction system, believe it or not. And so what happens is with WPW, they have this accessory pathway, and we'll say it's here on the epicardial surface going down there. And so they have this wave of depolarization moving across here, down through the AV node and across. And part of that impulse gets through that accessory pathway, and a wave of depolarization that comes from that area and meets with the oncoming wave. And so you get these two merging waves of depolarization. They call that a fusion beat. That's why you get a delta wave. Now, with WPW, you don't always see a delta wave in their underlying rhythm. But if you see it, it has a pretty high specificity for WPW. So it's incredibly cool, if in the field we can pick this up and actually show the hospital and say, Doc, is this unusual?
I don't know much about Parkinson's, but is it a congenital issue or is it?
It's congenital. Yeah, no, it's purely congenital. So those patients with Longenong-Levine, Mayhem fibers, and WPW, they have normally the only electrical link between the atrium and the ventricles is the AV node and bundle of His. But these guys have a little fiber. In the case of WPW, they call it the Kent bundle, and it usually travels along the epicardial surface, and it could be lateral or anterior or posterior, and it's just it's an accessory pathway, right? Mm-hmm. Yeah. Let's just see if I can draw it in big here. So you have two paths that collide. So this is a terrible heart. Well, let me try that again. Whoa, man, that was terrible. Bypass tract, yeah. So they have, here's their normal conduction system. And so they have this accessory pathway that normally the atria and the ventricles are isolated electrically by the fibrous connective tissue rings that support the valves. But they have this little muscle that makes its way through here. It's like a bridge, right? It's like a secret pathway. And so the wave of current goes down here, and it travels through the AV node and travels down the bundle branches, but it also comes from this location, and these two waves meet. And that's how we end up with that slightly wide QRS with a delta wave formation. So. Is it? If that's the case, I'm not aware of that. My understanding is it's just an anomaly that some people are born with. Not a fibrillation per se, but what happens is you get this circus movement tachycardia. They experience bouts of paroxysmal supraventricular tachycardia, and it happens because the impulse travels here and then circles back up here and forms this circus movement tachycardia. I'm sorry, my drawing is terrible here. I used to have a pen tablet and it worked beautifully, but it's really hard with a mouse. But I could do it on here, but I don't want to get too fancy, and take me a minute to set it up. But and I can't connect it to there quickly enough. But anyway, they have bouts of SVT, PSVT, and that's probably what happened to this guy. Is he had a short bout of PSVT, lost consciousness, and then regained it, and he was fine. So the parents were good enough to share the whole story with me. So just quickly in summary, because we're right at the end of the time. So the red flag things are pediatrics or older people, exertion, dyspnea, pain. These are big ones in my mind. If they fainted from a sitting position, from a lying position, that's really unusual, right? That's not a vasovagal episode. Cardiac disease, unexplained sudden deaths in the family, recurring episodes. Prolonged LOC, we start not to think about syncope. We start to think about other causes like hypoglycemia, some metabolic disorder, drug overdose or something. And any medications that affect cardiac induction, any abnormal ECGs. And again, really important to routinely look at QT intervals, do 12 leads routinely to look for things like Brugada Syndrome, to look for evidence of ventricular hypertrophy. If you're really good at ECGs, too, one of the causes of syncope is pulmonary embolus. And you can pick up signs on a 12-lead ECG of pulmonary embolus if you're really keen. So that's a little over the top for most people, but always fun to do, right? I mean, I've been at this for 26 years now. I learn something almost every shift. I'm always learning something new. So cardiac causes of syncope are associated with significantly higher morbidity and mortality rates. So that's what we really need to look for. We know most syncope is benign, but we need to look for those things that are life-threatening, or at least potentially life-threatening. And some of the must-dos that I recommend are, 1, always have a high index of suspicion. 2, always take a blood glucose for any altered LOC. Look for 12-lead changes. Look for rhythm changes. Do a thorough history of presenting illness or injury. Always look for the red flag history stuff. And lastly, this is kind of my mantra, and it's kind of a in distinct difference from what the physician was saying here yesterday from the College of Physicians and Surgeons, and that is, my mantra is, you call, we haul, that's all. I look at someone who's feeling well but they had a syncopal episode. I don't do this. Well, you're fine. You can go or not go. It's up to you. I don't do that. It's like, you're coming. Let's go. Kind of deal. So that's it. Thank you very much. Do you have any questions at all?